Good evening, everyone. So today we are about to discuss antimicrobial drugs, which is a very important topic for your practical Viva exam. Maybe if you are lucky, you might get a short answer from the same topic. So antimicrobials are classified based upon multiple things. One is this: it's pharmacokinetics and pharmacodynamics, or mechanism of action, or the spectrum of activity, whether they are acting against gram negative or gram positive or mixed coverage, etc., and the type of action that they are doing. Regarding pharmacokinetic and pharmacodynamic indices, as you can see, certain antibiotics are they base their effectivity about the concentration they reach, that is the peak concentration they achieve, that is concentration based killing, that is type 2, and the type 1 is type 1. The type 2 is time dependent killing. So that amount of the time that the organism exposed to that particular antibiotic above the effective MIC will give us better results. So these are time-based dependent killing which has minimum persisting effect. The concentration dependent killing that happens in type 1 pattern of activity that has persisting long-term effects. Even after the discontinuation of the drug, you will have continuing effect of that particular drug. And another type is type 3, where it has both of them, where the killing is happens on the time dependent basis, and at the same time the effect will be persisting on the organisms even after the brief discontinuation of the drug. That is why we have to consider a different modality to calculate these things, instead of simply the amount of the time exposed or the concentration etc. cannot be considered to see the effectivity of the medication. So in this particular case, we see the area under the curve. Depending upon the MIC, we consider the area under the curve over 24 hours, especially regarding mycomycin. We see the trough concentration, we see the peak concentration, and a particular formula will give you the area under the curve, the total duration with the effectivity and the concentration under which the organism went. Mechanism of actions, as we see, antimicrobials have an extensive ways of killing pathogenic organism. The most common and most well-known method is to disruption of the cell wall. So every microbial agent has its own protective coverage in the form of cell wall. Majority of these are gram positive organisms, and once you disrupt the cell membrane in the form of disrupting the building blocks, that lead to in pouring water, and that lead to osmotic changes in the cellular organelle, and that lead to final death of the organism. Those which prevent the cell wall synthesis, most common are beta lactam. Earliest identified was penicillin, and there are so many other antimicrobial agents that came in the form of synthetic penicillins, that are cephalosporins, carbapenems, and monobactams. And vancomycin and bacitracin also similar activity, and polymyxin also have cell membrane activity, not the cell wall. They effectively binds with lipopolysaccharide and disrupt the cell membrane, and that's how they kill the gram-negative bacteria, and that's the most important reason why they have their endotoxemic effect also. Another thing is this synthesis of the most important material for their replication, that is DNA. So folate synthesis is inhibited in the form of sulfonamide from conversion of para-aminobenzoic acid to dihydrofolate, dihydrofolate to tetrahydrofolate by sulfonamide and trimethoprim consequently. So especially the combination of this drug that is made in the form of Septron at a fixed combination will give you the best results. Another important building block for the organism is its protein synthesis, which requires ribosomes, and targeting the ribosomes will give us great effect in terms of their replication. Thus have great bacteriostatic activity, that is both 30S and 50S. There are like tetracycline and aminoglycoside acting on 30S ribosome subunit, and macrolides, clindamycin, linezolid, chloramphenicol, and streptogramin working on 50S subunit. Another important area of action is the DNA synthesis, where the DNA gyrase and topoisomerase can be inhibited by quinolones, and RNA polymerase inhibited by rifampicin. Now we will go into each one of them. We will consider both their effectivity and action and spectrum of activity and adverse reactions. As I discussed cotrimoxazole, so it involves both sulfonamide and trimethoprim acting at two different levels, from para-aminobenzoic acid to DHFA in the form of inhibition of folate synthase, and from DHFA to tetrahydrofolic acid by inhibition of dihydrofolate reductase. By this, they inhibit the synthesis of folate and leads to eventual cell death. So, regarding pharmaceutics available in the form of single strength and double strength, per oral tablets, good absorption, 80 mg trimethoprim and 400 mg of sulfamethoxazole. IV also similar combination. Indication, most common indication in our critical care setups is PCP pneumonia, both in case of suspicion and also in the form of prophylaxis. And it's a very good drug for an extensive wide spectrum activity for prophylaxis, even in post transplant candidates also. So infection, 5 mg per kg body weight of trimethoprim component every 8 hourly. As a prophylaxis, tab single strength once daily or double strength twice a week. Other extensive coverage involves stenotrophomonas, nocardia, toxoplasmosis, and some gram-positive cocci also. Trimethoprim sulfamethoxazole requires renal adjustment when the GFR gets less than 30 to 50 ml per kg per minute. Adverse effect include, most common is GI upset, photosensitivity, hemolysis. When the hemolysis happens, obviously there is a possibility of methemoglobinemia. Other hematological side effects includes granulocytosis, aplastic anemia, hemolysis, and thrombocytopenia. So why it is important? Because most of these patients are already immunocompromised and they have bone marrow suppression. It is very difficult to discriminate the effects of immunosuppression from the drug, but also you should keep these particular side effects in your mind. Multiple drug interactions are also known, especially the AC inhibitors, where it might lead to hyperkalemia. So always keep it in mind when the patient is going into hyperkalemia. So you should consider the drug interactions. And methotrexate, as I told you, it has itself having an effect of in bone marrow suppression and thrombocytopenia. But at the same time, it enhances the effect of methotrexate, might lead to enhanced marrow suppression also. So at the same time, as we discussed, AC inhibitor like spironolactone, hyperkalemia, and for warfarin, it increases the activity and effectiveness of warfarin that leads to increased INR. Beta-lactams, all beta-lactams are derived from the penicillins. They have a basic code beta-lactam ring, which is a very signature thing for them. The synthetic ones are cephalosporins, monobactams, and carbapenems. Mechanism of action, as we discussed, they are affecting the bacterial cell wall structure. The protein binding, penicillin binding proteins are attached, and which in turn inhibit the final transpeptidization step of peptidoglycan synthesis of bacterial wall that leads to porous cell wall and cell death. So these are bactericidal in behavior. Natural penicillins, penicillin G, benzathine penicillin, which are very rarely ever used nowadays, except in case of rheumatic fever. The aminopenicillin, amoxicillin, ampicillin, which we commonly use mostly in a patient who has no additional exposure or no repeated hospital acquired diseases. Anti-staph penicillin, oxacillin is specifically targeted. Even today also, if you find a patient who is having susceptible Staphylococcus aureus, the drug of choice will be oxacillin. Anti-pseudomonal agents, carboxy and iridopenicillins, that is ticagrelin and piperacillin. Amoxicillin and clavulanic acid, it's a combination of penicillin and its enzyme inhibitor. Gram-positive aerobes covered under is methicillin sensitive Staph aureus. Gram-negative aerobes includes Enterobacter species, that is E. coli, Klebsiella, etc., and Haemophilus and Moraxella. Most common use in our setups is pneumonia, otitis media, and sinusitis, especially this. So, regarding many of the upper respiratory tract infections, it is highly effective. Adverse effect includes diarrhea, otherwise, it is very well tolerated. Piperacillin, tazobactam, spectrum of activity is again extensive. Methicillin sensitive Staph aureus is the very common usage. Gram-negative microorganisms include both Acinetobacter baumannii, E. coli, Haemophilus influenza, Klebsiella pneumonia. So, majority of the community-acquired pneumonia can be targeted with piperacillin and tazobactam. Gram-negative aerobes are Bacteroides flagellus group. Current usage, both hospital-acquired pneumonia, community-acquired pneumonia, intra-abdominal infections, and skin and subcutaneous infections. Dosage 4.5 grams every 6 to 8 hourly. In case of Pseudomonas, it is 6 hours. Otherwise, generally we tend to go for 8 hours dosage. Renal adjustment needed when the creatine clearance comes down to less than 40 ml per minute. Hemodialysis requires additional dosage. There is a recent trial comparing piperacillin tizobactam with meropenem also, which is we considered as one of the most effective broad spectrum antibiotic, and it showed non-inferior in terms of 30-day mortality. Adverse reactions include thrombocytopenia and diarrhea. Cephalosporins, they are classified into multiple generations, generation 1, 2, 3, 4, 5. As the generations advances, majority of them having narrow spectrum. Earlier generations have a wider spectrum of coverage, especially the gram-positive coverage. So generation 1, cephalexin and cefazolin, they have a wide gram-positive coverage. Generation 2 increase the coverage to more into gram-negative, and third generation cephalosporins are extensively gram-negative directed rather than gram-positive directed. Again, when it comes to final fifth generation cephalosporins, which is very much directed against methicillin-resistant strains of gram-positive coverage and limited gram-negative coverage. The first generation is active against gram-positive organisms, as I told you, and fifth generation is more directed against MRSA. Indications in our setups includes both community-acquired pneumonia, septicemia, meningitis, especially because they can penetrate through the blood-brain barrier. Ceftazidime, cefoperazone has especially anti-pseudomonas activity. Most common side effects are neutropenia, thrombocytopenia, and transaminitis and disulfiram-like reactions. Aztreonam is another, cephalosporin, so same group of antibiotic monobactam that inhibits cell wall synthesis, metabolized in the liver, resistance to beta-lactam. So that's why the organism which produce beta-lactam has no effect on Aztreonam. Active against an extensive range of gram-negative bacteria. Gram-positive coverage is very less. Can be used in patient allergic to beta-lactam rings, and also ceftazidime. IV nebulization formulations are also available. So it acts stable in the presence of amber class B, that is metallo-beta-lactoproteinase. Dosage generally 1 gram IV thoroughly. Systemic infections and urinary tract infections and life-threatening infections like Pseudomonas aeruginosa. Nowadays we use Aztreonam more as a combination with ceftazidime and ceftazidime with avibactam. Renal adjustment is needed in case of compromised kidney function. Adverse effects are very few, includes serum sickness, positive Coombs test, C. difficile diarrhea. And now comes to carbapenems. Carbapenems include a few important drugs that are imipenem, meropenem, doripenem, etapenem, and recently a new drug has come, that is biapenem. Imipenem originally used extensively for intra-abdominal infections, and majority of the imipenem is rapidly metabolized by renal dihydropeptidase 1 enzyme. So that is why we use it along with cilastatin. Cilastatin inhibits DHP1. That's why it both increases the concentration that is required to kill the bacteria, at the same time decreases the overall nephrotoxicity effect of imipenem also. Regarding the other penems, they are extensively used as a broad spectrum coverage both for gram-negative and also to an extent gram-positive. Anaerobic organisms include Bacteroides flagellis, and as you know, it has a decent coverage regarding anaerobes also. So whenever you are using meropenem, probably you don't need any additional anaerobic coverage in the form of metrogel. Doripenem has relatively low seizure threshold, so no particular selection for it unless the patient is having any risk of seizures. Etapenem especially not so much useful in our settings because nowadays we see a lot of patients with Pseudomonas aeruginosa, etc. Dosing as you can see, all these things are needed renal adjustment according to the renal parameters. Majority of them has to be reduced at less than 40 to 50 ml per minute at GFR, and they require additional dosing post hemodialysis. CRRT dosage usually will be the full dosage. And fluoroquinolones. Fluoroquinolones, they have extensive coverage, one of the extensive covered antibiotics, but they have their own side effects. That's why we have limited usage in the ICU setups. Includes gram-negative and gram-positive coverage. First generation, norfloxacin and naldixic acid, great gram-negative coverage. Even today also, gram-negative infection through urinary tract, the drug of choice is first generation norfloxacin. In case of other hospital-acquired pneumonia, etc., the including atypical coverage, levofloxacin is a great agent. We rarely use the second generation nowadays, and there are additional new antibiotics that are coming belonging to fluoroquinolones that we will be discussing in newer antibiotics. Bactericidal in nature, so mechanism of action, as we already knew, that it binds complexes with DNA, two agents that are DNA gyrase and DNA topoisomerase 4, results of cessation of replication that leads to bacterial killing. Majority coverage is gram negative. Gram negative is extensively covered by Cipro, followed by levofloxacin and moxifloxacin. Streptococcal pneumonia, as we know, that our drug of choice in majority of the cases is levofloxacin for community acquired pneumonia, and it is as effective as moxifloxacin. Most of the drugs are covered for MSSA, and for MRSA, the newer drugs are available. Regarding their antimicrobial activity, they are part of the modified ATT medication list also. Other bacterial agents that include under coverage are Bacillus and Francisella, and also for typhoid, they are first line of agent. Fluoroquinolones, oral bioavailability is almost 100% for levofloxacin and ofloxacin also, and 70% for ciprofloxacin. So they are very simple medications that can be even prescribed at oral route, those who have functional GI tract. Regarding ciprofloxacin, oral is 500 mg/d, IV is 400 mg/d, and they require creatine clearance based adjustment. Again, adverse effect includes QTC prolongation. So before initiating these antibiotics, you should go for a 12 ECG, look at the QTC, and probably you need to follow if it is borderline daily with a 12 ECG. Aminoglycosides both systemic, topical, and they are now getting popular in the form of inhalational usage also. Systemic includes streptomycin, amikacin, gentamicin, and tobramycin. Topical mostly we use in the form of neosporin, neomycin. Aminoglycosides mechanism of action, as we saw, it is effective through ATS ribosomal subunit binding and inhibition of translocation process and inhibiting the RNA synthesis. Spectrum include extensive gram negative, gram positive, and to an extent mycobacterium also. That is why it is part of modified ATT regime also. Indications include combination of antibacterial therapy, complicated UTI, and antimicrobial drug, antimicrobacterial. Dosage, amikacin 15 to 20 mg per kg OD, and for gentamicin it is 5 mg per kg. Adverse reactions, it is very notorious to cause nephrotoxicity and ototoxicity. So what we can do is, majority of these drugs are OD medications. So you can give the medication as a stat dose, and you can follow the creatinine value the next day. Probably you can continue it on a daily basis by closely monitoring the renal function test. And they have a peculiar neuromuscular blockading effect also. This comes from the same manner the verapamil acts, that is the calcium channel blockade, that leads to decreased calcium influx at the motor end plate, leading to decreased acetylcholine availability at the motor end plate. Generally, this is not so significant, but in critically ill patient, along with steroids, etc., it might lead to critical illness neuromyopathy. Glycopeptides, we popularly know the vancomycin and teicoplanin. Extensive activity against gram-positive coverage because of their ability to inhibit the cell wall synthesis. Spectrum include both MRSA and MSSA, Enterococcus faecalis, and Streptococcus. Indications, as you know, most of the MRSAs are covered under vancomycin and teicoplanin also. Oral vancomycin, especially for C. difficile infection, as it is very less absorbable through gastrointestinal tract. Vancomycin dosage, it has to be started with a loading dose of 25 to 30 milligrams per kg. Why? As we already discussed, the concentration makes a great deal of effort in killing the microbacterial agents, the bacteria. So we have to achieve the concentration early. So load every time, followed by the maintenance dosage. Check trough levels through fourth dose, and also follow the peak levels so that you will get the area under the curve. Renal adjustment needed. So those who are on hemodialysis, every post hemodialysis you need to give additional dosage. On CRRT, it is 500 mg every 24 to 48 hours. Adverse effect, it is a nephrotoxic agent. So generally, most of the patients, those who are already on maintenance dialysis, it is the best drug. You need to follow the kidney function also. So vancomycin is normally bactericidal against Staph aureus and pneumococci, but bacteriostatic against enterococci. Teicoplanin, not currently licensed for US, so bacteriostatic in effect, we extensively use them for gram-positive coverage. Very less adverse effect, very rarely ever we see thrombocytopenia. In our routine usage, we hardly see any additional side effects. Renal adjustment is needed. Usually we load with 400 mg 12 hourly for 3 doses followed by 400 mg OD if there is no renal compromise. Otherwise, dose modification needed at creatinine clearance less than 30 ml per minute. Not removed by hemodialysis, and spectrum of activity is very close to vancomycin. Another drug is linezolid, which is extensive gram-positive coverage, and it is again specifically reserved for MRSA agents, skin and soft tissue infections. Mode of action is inhibiting the bacterial protein synthesis, especially the 23S ribosomal RNA 50S subunit. So here 50S also has a subunit, that is 23S, which gets inhibited by linezolid. So dosage is 600 mg IV. Oral absorption is excellent, almost 100%. No need to adjust the dosage. Indications: vancomycin resistant enterococcus and MRSA pneumonia, skin soft tissue infections. Linezolid, the popular adverse effect that we know is thrombocytopenia. Those whoever is getting linezolid and going into thrombocytopenia, the drug needs to be stopped and observed. And hyperglycemia. Generally, this drug-induced thrombocytopenia will not start right away. It will take its own time, probably 5 to 7 days only. So if the thrombocytopenia happens on day 2, day 3, you should assume it is because of mostly sepsis-related thrombocytopenia. Macrolide antibiotics, erythromycin, clarithromycin, azithromycin, mostly they cover the atypical agents. So mechanism of action, synthesis of proteins by inhibiting and binding to 50S ribosomal subunit. Dosage, clarithromycin 500 mg BD, renal adjustment needed, and they all affect the QT interval. So again, in this particular case, macrolides, you need to check the 12 EDCG, check the QTC if it is borderline, or even if it is normal, you have to follow the 12 EDCG on a daily basis, especially in elderly and those vulnerable populations. Spectrum of activity, extensive gram-positive and negative coverage, but we do not use them for gram-positive, gram-negative coverage on a daily basis, but atypical coverage, as it is mostly a drug of choice for Legionella, Chlamydia, and Mycoplasma in community-acquired pneumonia, and also Mycobacterium avium complex. Absorption, excellent oral absorption, compromised by food depending upon the food intake. Clarithromycin is well absorbed regardless of the food presence, and erythromycin food decreases the absorption. So you can give just taking before taking food. Very poor CSF penetration, so not useful for any CNS infections. Inhibitors of cytochrome P450, so you need to very closely monitor all the anti-epileptic medications, and maybe with the increased concentration of theophylline phenytoin, there is a risk of arrhythmias. Side effects are mostly hepatotoxicity and QTC prolongation, so patient might develop VTPF, exhibits immunomodulatory effect also. Tigecycline, mostly favorite drug for gastrointestinal surgeons and gastroenterologists, and especially in GI units because of its increased accumulation through different bodily fluids, includes both abscesses and even in the lung also. It gets in lung abscess also it gets into very high concentration. So glycycline, antibiotic derivative of minocycline. Mechanism of action again binding to 30S ribosomal subunit. Liposomal lipophilic activity, so it has an extensive drug distribution, thus having rapidly distributed into tissues from the blood intravascular space. Bacteriostatic in behavior. This is one important thing you need to consider. It will not kill the bacteria, probably it will provide enough time for the body and prevent the bacterial rapid growth. Indications is skin and soft tissue infections, intra-abdominal infections, and community-acquired pneumonia also, but it has a black box warning for it. So dosage is 100 mg IV followed by 50 mg BD, and regarding liver diseases, especially in child C, because of the decreased elimination, loading dose will be 100 mg followed by 25 mg BD. High dose in case of breast infection, especially the gram-positive coverage, where you don't have any other medication that is available, especially Staphylococcus, where it is resistant to both VAC and linid. You have to give it in a high dose, that is 100 mg BD. Primary route of elimination is biliary excretions. And TG-cycline also associated with increased levels of bilirubin over a period of time, almost 8 to 10%. Its renal elimination is close to 16 to 18%, I think. So if you don't have any other medication that is available for UTI and you see enterococcus faecium, probably only sensitive to TG-cycline, you might consider it, but not an indicated drug. So spectrum of activity: MSSA, MRSA, Streptococcus and E. faecalis, Klebsiella, E. coli, Acinetobacter, all these Enterobacter species in intra-abdominal infections. Not active against Pseudomonas and Protea species inherently. It has a black box warning for TG cycle should be reserved in use situations where alternative regimes are not available, because certain trials were done where they showed overall mortality is on the higher side in those TG cycline used as a single agent. Use of resistant bacterial empirically is not an FDA approved. When it comes to polymyxins, these are very old drugs, not so popular, almost got out of fashion in 90s. Then they have come back to vengeance because of the increased antimicrobial resistance that is going on, and not as a single monotherapy but in combinations. So 5 types of polymyxins are there: A, B, C, D, E. What we are going to discuss is only polymyxin B and polymyxin E, that is colistin. These are essentially bactericidal drugs because they bind with lipopolysaccharide membrane, disturb the membrane, that leading to cell wall destruction. So competitively displace divalent cations from the phosphate group of the membrane lipids, lead to disruption of outer membrane. So spectrum of activity: extensively gram-negative coverage, not at all gram-positive coverage, resistant inherently to Burkholderia sepia, Serratia, Proteus, and Providentia and Morganella morgani. For these things, it is inherently resistant. Gram-positive bacteria also, it has no effect. Comparing the polymyxin B and colistin, colistin is a prodrug. So colistin has to get activated inside the body after getting inside the body. That is why it requires number one loading dose, and it needs to be activated. So it will take its own time for the activation. On the other hand, polymyxin B is a ready-made active agent, so it achieves the immediate action and the concentration that is required. Drug levels of the polymyxin B are not affected by renal function because it is not excreted by kidney. That is why it cannot be used for UTIs. Colistin, there is confusion generally around the dosage. So 2.4 milligrams of colistin methyl sulfate is equivalent to 1 milligram of colistin based activity, which is again equivalent to 30,000 units of international units of colistin. So whenever you are prescribing, the usual dosage in the form of 9 million units loading followed by 4.5 million units BD. It needs renal adjustment in case of renal dysfunction. As you can see, as less than 50 creatinine clearance, you need to adjust the dosage. Regarding hemodialysis, it needs loading dose followed by 130 mg post dialysis after dialysis, and CRRT 300 loading followed by 220 every 12 hours. Polymyxin B, now the polymyxin B is extensively used because of its less nephrotoxic effect. The loading dose will be 20,000 international unit as loading followed by up to 25,000 international units in 2 divided doses per kg body weight. Recommendation says less than 2 milligram per liter as intermediate sensitivity, whereas less than 4 at a resistant category. If available, other agents should be strongly considered, should not be used as a single agent, always combined with other gram-negative bacteria antimicrobial drugs to increase the effectivity and prevent resistance. Fosfomycin, it has similar behavior in terms of activity. It has extensive gram-negative coverage. It is a bactericidal agent. Spectrum of coverage includes both gram-positive also, but we consider it for gram-positive, especially Enterobacter species, includes E. coli, Klebsiella, etc., and Salmonella Streptobacter. Resistance, fosfomycin resistance is usually seen in Acinetobacter and Pseudomonas. Indications is UTI in the form of oral sachet also, if it is not complicated as a single dose, and if it is complicated as 3 sachet, we give it on alternate days. And for septicemia, systemic septicemia, up to 24 grams per day. And one thing you need to consider for fosfomycin is it has a very high levels of sodium in the drug. So once you started giving the drug, the sodium level will start raising. So always try to dilute the drug with 5% dextrose to mitigate such an effect and closely monitor the sodium. It can be used both in case of osteomyelitis, hospital-acquired pneumonia, meningitis, but resistance is documented. Once you start using the drug, the resistance arrives very early. So never use it as a single agent, always combine with some other gram-negative coverage. Those renal modification is needed at creatinine clearance less than 40 ml per minute. And now we comes to newer antimicrobial agents. Most popular among newer antimicrobial agents is ceftazidime and avibactam, which we have extensive experience. It's a third generation cephalosporins alone. Ceftazidime is though it is active against pseudomonas. Now the resistance is going up a lot. So alone ceftazidime is not going to make much difference unless the culture sensitivity report clearly says it is sensitive. But otherwise, as an empirical therapy against especially the Klebsiella and pseudomonas, it has to get a combination of treatment with avibactam. Avibactam administered at a fixed ceftazidime avibactam combination of 4:1, approved for the treatment in adults for complicated urinary tract infections and complicated intra-abdominal infections and hospital-acquired pneumonia, including ventilator-associated pneumonia. These are only three approved indications at this point of time. Ceftazidime avibactam in vitro activity, it's excellent against many gram-negative pathogens, especially ESBL, AMC, KPC and OXO48 producing enterobacteriaceae species, and also drug-resistant Pseudomonas aeruginosa isolates. UCAST MIC breaking points given less than 8 mics per ml as susceptible and greater than 8 as resistant. Ceftazidime avibactam has almost no activity against Acinetobacter, Stenotrophomonas and metallobutolactamase inhibitor producing strains. Mechanism of action, it has third generation cephalosporin that is ceftazidime, binds with penicillin binding protein, but it will get easily inhibited by the particular beta lactamase that is serine beta lactamase, which is inhibited by avibactam. PKPD, it again follows the time-sensitive, time-dependent killing. Both ceftazidime and avibactam exhibits low levels of human binding protein. Neither drug is metabolized by any great extent, with both drugs primarily eliminated unchanged in the urine. Both are removed by hemodialysis. Renal adjustment needed at creatinine clearance less than 50 ml per minute. Adverse reactions include just like any other cephalosporins, the phlebitis, skin rash, diarrhea, and vomiting. Ceftaroline, it is a fifth generation cephalosporin. As we discussed, it is greatly active against methicillin-resistant Staphylococcus aureus, especially in acute bacterial skin and skin structure infections and community-acquired bacterial pneumonia. Inhibits bacterial wall synthesis by binding protein binding penicillin binding proteins, time-dependent killing. Protein plasma binding is less than 20 and eliminated through renal excretion. Ceftaroline, Hemdia gram-positive bacteria, especially in MRSA and vancomycin-resistant Staphylococcus aureus and Streptococcus pneumonia and Haemophilus influenza. So, community-acquired gram-positive coverage is excellent in pneumonia, and gram-positive anaerobes include Peptostreptococcus and Propionibacteria. Does not possess any activity against gram-negative bacteria. So this is one fallacy. When we think it is some fifth generation cephalosporin, should be having some gram-negative coverage. It does not have any extensive gram-negative coverage. FDA approved only for skin and soft tissue infections. Dosing is 600 mg IV 12 hourly and has creatinine clearance less than 50 requires creatinine renal adjustment. Again, the side effects include similar to the cephalosporin agents. Another important drug is meropenem and vaborbactam, approved by US FDA recently in 2017 for carbapenem with beta-lactamase inhibitor combination. Approved indications include complicated urinary tract infections, potent activity against KPC producing strains, because KPC producing strains generally destabilizes the meropenem. So vaborbactam prevents the KPC producing organisms bacterial destruction activity. So thus it increases the effectiveness of meropenem. Mechanism of action, inhibiting the cell wall, similar to other penims. Vaborbactam is non-suicidal boronic acid beta-lactamase inhibitor with no bactericidal activity on its own. So it cannot be used independently other than in combination. So it prevents beta-lactamases such as KPCs. Time-dependent killing, protein binding, similar in case of meropenem it is only 2%, vaborbactam it is 33%, excreted primarily through kidneys. Usual dosage is 4 grams in every 8 hourly and requires renal adjustment in case of decreased creatinine clearance. Adverse effect, again similar to other penams. Another important medication is arbicacin. Arbicacin is used for the treatment for MRSA infection both in Japan and South Korea almost for 15-20 years, and it has proven effectivity with MRSA and recently getting approval in other countries also. It has antibacterial activity against high level gentamicin resistant enterococci, MDR, Pseudomonas aeruginosa also. Mechanism of action, it binds to both ribosomal subunit 50S and 30S, leading to decreased translation. Concentration dependent killing, excreted primarily in the urine. Bactericidal activity similar to vancomycin, but it's better to vancomycin in terms of its effect. Dosing is 200 mg once daily. So it requires renal adjustment in case of decreased renal clearance. Yeah, adverse effect include nephrotoxicity and ototoxicity. Another important medication is levonoride-fluoxetine. Levonoride-fluoxetine is the prodrug is alla-levonoride-fluoxetine. It is synthesized from alla-levonoride-fluoxetine. In the form of prodrug, the usual dosage is 1 gram 12th hourly. As the active drug levonoride-fluoxetine, it is 800 mg 12th hourly. Broad spectrum benzoquinoline. It's part of fluoroquinolone group. So unique structure that is attributed to tricyclic core with absence of conventional amines at C8 position of the side chain. It gives it special characteristic being more active against gram-positive bacteria. So mechanism of action, net acidic charge on the molecule leading to greater affinity to DNA gyrase, leading to decreased synthesis of DNA. The pharmacokinetics dynamics are area under the curve, MIC, bacteriostatic and cidal activity, both will be seen. Indications include acute bacterial, both skin and soft tissue infections, and concurrent bacteremia. Highest lung penetration among the quinolones. Spectrum of activity, though there is significant gram-negative coverage is also there, we extensively use it for gram-positive coverage. Dosing, as we already discussed, the levonoride-fluoxetine is 800 mg BD. The prodrug alla-levonoride-fluoxetine is 1 gram BD. No dosage requirement, no dosage adjustment is required both for renal and hepatic adjustments. So what we have to do in terms of selecting the antibiotic for a particular disease is now we have advanced investigations including gene testing. We see various beta lactamases they produce. You have to go through the blood classification based upon that, depending upon the different beta lactamases your gram-negative bacteria are producing. You can select appropriate antibiotic. That itself is a separate topic, but you have to go through it. It is very important. Anybody can ask the questions about blood classification. All the antibiotics that we discussed again need to be titrated upon what kind of organism you are getting, what is the culture sensitivity report, and what is your institutional culture sensitivity bacteriogram that determines what is the most common organisms you get. So depending upon that you have to titrate. It is very important to independently titrate your therapy according to the situation to the patient rather than blindly just going through certain antibiotic. Thank you.
शायद हो जाएगा, देखते हैं बच गए।